All right, I think we'll get started. Um, for everybody on this will be recorded. Uh, I will probably use this going forward, in some of the classes, at least initially, maybe have you back or Jacob. Um, but today will be the fourth of the series that we're putting on that discusses the nurse practitioner role in critical care transport. We started with Keith Evans from Vanderbilt, and then Dave Holloway was on from the Cleveland Clinic. Last week, or not last week, but the last one was Robert Grabowski, who was with Metro Lifeline and now is helping Nebraska Children's start their team led by nurse practitioners. And today we have Jacob Miller, who has experience both at the Cleveland Clinic flight team as well as it's Cincinnati Children's, right? What's
University of Cincinnati, UC Health.
University Cincinnati flight team? And some people are new. Some people have seen this before. This will be on YouTube, and I want to answer the question on why we're doing these interviews. And really, my big goal is to raise the awareness of nurse practitioners in critical care transport. We teach a program that focuses on NPs in critical care transport. However, there's only a select few programs in the country that use them. So what I hope to do is not only educate those who want to become nurse practitioners in critical care transport about the role, but also kind of share best practices with administrators who may be considering this model, with the ultimate goal to have more programs who use these NPs in critical care transport. So today we'll discuss their value. We'll share best practices and perhaps not so best practices of NPs in CCT. And aside, I guess, objective for me is to tell people about our program and what we're doing at CASE to help really promote and drive this model of advanced practice providers. I say NPs, but I really include PAs in that kind of level. There are some differences in practice, but to drive this model of nurse practitioners and advanced practice providers in critical care transport. This paper is now out. It was published a couple months ago. I encourage you to read it. Basically, I spoke with a lot of the leaders who are instrumental in their programs as far as using NPs and CCT, and we share our insight to this role. And with that, I think I'll turn it over to Jacob Miller, who went through our program. He was already a flight nurse, so I think regardless of coming through our program or not, would have eventually become a NP in transport. I'm just going to hand it over to you, Jacob. You can tell us about yourself, and then Tanner and I have a list of questions that we hope you'll address.
All right, absolutely. So thanks for having me and thanks for inviting me out here to talk to everybody about the role of NPs in transport. My background, I'm from the Western New York area, Buffalo area, and I worked pretty much in high school. I went and got my EMS certification as a first responder, then an EMT. I was a junior firefighter with the local fire department. Once I got my EMT, I joined the local volunteer ambulance corps in my hometown. Quickly realized that volunteer means you don't get a paycheck, and apparently everybody in life wants you to pay for stuff. So that didn't work out very well. So I did get my first job was actually my real first job was working at a pizza place, as most teenagers do. But my first adult job was working for the ambulance. I worked for Rural Metro back when they were Rural Metro in Buffalo, New York, and they covered a pretty large territory. And through that, working up through the ranks of EMT, advanced EMT, paramedic, got a little bit of exposure to critical care transport and flight because that's just the way that the game goes. And certainly, right out of high school, I went into college for my nursing degree and got a job at the region's level 1 trauma center out in Buffalo at ECMC. So in those days, the laws in the state of New York were that they would not hire any new grads. Like they were prohibited by law from hiring a new grad into the emergency department. You had to have a year of nursing experience. Didn't matter where, we had to have a year of nursing experience. So I got my year, conveniently timed it where my year was also during my paramedic program. And then as soon as I finished that year of purgatory on med surge, I went into the emergency department and started working as an emergency department nurse. So at that point, I was working as a nurse and a paramedic, nurse in the hospital, paramedic in the field. And, by no stretch of the imagination did I have anywhere close to the 3 to 5 years of experience that's really required and personally strongly endorsed for getting into a flight position. So I guess the first thing that I want to say about that is I was that idiot nurse that went from the emergency department into flight and critical care transport. And I guess I didn't really, the whole Dunning-Kruger effect is very much alive and well. Like you don't know what you don't know sometimes. So for anyone who's not yet in critical care transport, personally, I strongly endorse getting ICU experience to be a flight nurse. Can you do it with emergency department training only? Absolutely. I mean, obviously I did it and I feel like I've been moderately successful in my career. But I think that there's a steeper learning curve because, whether you have an advanced practice clinician on your transport team or not, the vast majority of programs in the States, as we all know, are predominantly run by a registered nurse with a paramedic. And therefore, all the stuff that the registered nurse from the emergency department brings with them, the paramedics pretty much bring that as well. What the complement is nicer when that nurse has a little bit more of the critical care understanding. Now, if you look at a critical care nurse and a critical care paramedic that have both been flying for 10 years and they've been flying together, I would hope you wouldn't be able to tell which one is which, and they should really be able to run the gamut together. But for that initial training, I really do think that it's helpful for the nurse to have that ICU background because that's something that in most states, paramedics just plain and simply cannot get. So learning how to work the ventilator, learning how to multitask your infusions and figure out when they're on 15 different infusions and you've only got 10 pumps, which ones do you cut off? Those types of things are very helpful for getting into transport. So fast forward a few years, I ended up starting flying with Starflight Medevac. They're now a stat medevac base down in Jamestown, New York. And shortly after that, I realized that I really wanted to do this at a higher level. I really enjoyed the autonomy, but unfortunately, as many nurses and paramedics understand, there's a lot of patients that don't fit squarely into our protocol sets. And it just didn't feel right to me to have to either call med control on every single transport because I wanted to adjust a medication that was just slightly outside of our protocols, or just blatantly ignore the fact that we have protocols, do it on my own, even though I'm not licensed and credentialed to do so. So I end up going to the I ended up going to the acute care program down in Baltimore, Maryland, got my acute care nurse practitioner and clinical nurse specialist training, and then moved from there up to Case Western in Cleveland to do the postmaster's flight certificate. There's political reasons why I didn't do the acute care training in Case Western, but those are neither here nor there. Actually, the reason was because they also did not accept anyone without ICU experience into their acute care program. So that's the only reason I went to Baltimore versus going to Case Western for my acute care training. And then pretty much concurrent with that, I got hired on Dave Holloway, who spoke in this venue a couple months ago. He actually was the hiring manager when I applied for Cleveland Clinic, and he hired me on as part of their team. So I did fly as a flight nurse practitioner with the Cleveland Clinic. It was actually my first NP position. So there's a wonderful discussion we can get into that as should NPs in flight have NP experience or is nursing experience sufficient? So that was my first NP position, and my first flight NP position was with the Cleveland Clinic. I was there for about 4 years. And then I realized that I kind of really missed the scene work that I used to do back in upstate New York. And the schedule flexibility that other providers have throughout the health systems. Many providers don't necessarily work 3/12s a week. They kind of work, 12/12s a month or something like that. So the combination of those two things led me down to Cincinnati, where for 4 years I flew down here as a flight nurse practitioner with the air care team in University of Cincinnati at UC Medical Center. So that's kind of been my background and my bounced around and all that sort of stuff. But I think the other thing that's important to mention is kind of in the post-COVID fallout about a little over a year and a half ago now. So it was October of 2022. We were all called in on a meeting with some very important people. And no meeting that has a lot of very important people ever goes well. They're not saying like, hey, by the way, we're promoting all of you guys. What ended up happening was the hospital had some very difficult financial decisions to make. And among those financial decisions, they cut back the hours of the flight program to get up to in total. But along with that, they also eliminated the flight nurse practitioner program. So myself and I think 7 of my other colleagues were basically said, you've got 120 days, and we wish you luck, but you don't have to go home, but you can't stay here, kind of thing. So with that, I kind of explored my options and ended up settling on accepting a position, also still with UC Health Air Care Mobile Care. But I moved into a role of the clinical educator, which is an RN level role, but they've got 2 different, I guess, hierarchies. So they've got like a nurse educator who's a undergraduate or graduate, or they have a nurse educator that's undergraduate prepared and a nurse educator that's graduate prepared. So obviously I was able to get into the higher tier there. But with that is an RN level position. So I'm not officially functioning as an advanced practice nurse right now. Because I was previously credentialed on the aircraft, I am able to pick up flight shifts. In fact, I have a flight shift coming up this weekend, and flew one a couple nights ago. But with that, I'm functioning as a registered nurse. So I'm not functioning in the advanced practice role. So I have all the restrictions of RN practice that come with it. So some of the advanced procedures that I was able to do, I'm no longer able to perform. Some of the decision making that I was able to perform in the past autonomously may require a call to medical control. So, but that's the model that we're in right now. And I think that there's also some good explanation or some good considerations for why that might have happened. And we can certainly delve into that a little bit as well, because when we're looking at building best practices and we're looking at building a system that supports advanced practice providers in the critical care transport environment, I think that it's important to know what's working well, just as important as it is to know what's working not so well. And when we're building these systems, we want them to be resilient against change, resilient against, someone coming in and saying, hey, this just isn't working out. Cool that you guys were all here, but, thanks, see you later. Because I think that's not going to lead to job satisfaction for anyone. There was a lot of very difficult emotion that was expressed during that time, and I think rightfully so. I've been called out on that by other folks, about the way that I reacted, and I think that it's kind of helpful to understand. So some of it is introspection to look at like, okay, yeah, probably shouldn't have said that. But also some of it is like, okay, how would you feel if you got the dream job that you loved, that you wanted to do nothing else, and all of a sudden you were told, goodbye, it's not you, it's me, we're breaking up though. So I think that there's a lot of consideration we put into that as well. So that's kind of my background. That's the long rambly road that took me to where I am right now. Still don't know what I want to be when I grow up. I would love to be able to fly as an NP again somewhere, but I don't know when or if that's going to be in the cards. So that's where I am.
Yeah, there's a lot of things we'll get into within that. I wanted to interrupt you a lot, but I knew the questions were coming later, and we'll get into probably a lot of sub areas of that. People who are listening, if you want to ask a question, the chats are open. Do you have your chat open, Tanner? I have mine. We'll watch.
Yeah, I'll cover the chat.
Yeah, we may not answer them quickly because we know that will be asked down the road in a slide or so. I think we got your experience. Thank you, Jacob. As far as CCT programs, you said
Yeah,
before.
so I started
Yeah,
so I started working out as a nurse paramedic with Starflight Medevac in Jamestown, New York. I worked for them for a couple of years, and I went to grad school, and I kind of came back during/after grad school. So there was a short period of time where I was actually, well, we'll get there. So I went to grad school in Baltimore, Maryland, and I actually worked for University of Maryland Medical Center's transport team. The way that they had done it, their nurses were employed by the hospital, but their paramedics and their EMTs and the vehicles were contracted to a third-party service. So I didn't work directly for UMMC. I worked for the third-party ambulance as a paramedic. And so I worked as a transport nurse with that team, but they weren't the Maryland nurse. They kind of did the backup runs for Maryland. And then I also was dual credentialed as a paramedic. So I frequently would actually pick up the paramedic position on UMMC's ground critical care transport service. So that's kind of how I did that. And then I moved up to Cleveland and started working within my first year is when I got hired on with Cleveland Clinic's team. So there was a short period of time where I actually was living in Cleveland, working in New York with a PRN position in Baltimore, if you want to try to triangulate that one. So those were my first three transport programs. And then the last CCT program that I worked for, obviously, is UC Health Air Care Mobile Care. So Starflight was rotor only. We would do ground runs if we were weathered in. My Baltimore was actually ground only. Rotor was done by a separate program. In Cleveland, we did everything. You know, we did ground, we did rotor, we did international and domestic fixed wing. And then down here in Cincinnati, we have a rotor as well as ground critical care transport.
So total years, we're talking around 10, 8?
Total years. So my first flight program, I think my first flight position, I believe, was 2012. So about 12 years now that I've been in critical care transport.
Half of which would be as a nurse practitioner, roughly.
Well over half, I think. So I started 2012 with the first flight position. My first position at Cleveland Clinic was 2015. So about 9 years as a flight NP now.
All right, I'm going to ask a question I get asked a lot, and I love the fact that I don't have to just give my opinion, and there's other people in the industry now that can share. What's your feeling about flight nurses or nurse practitioners having to be a paramedic or EMT? Do you feel that's a requirement, that's a needed requirement, or do you think it's okay for, let's say, ICU nurse to not be a paramedic or EMT and fly?
So what I think, so truly what I think is that, do they need to be a paramedic, a certified paramedic? No. What I really like is the way, for example, Pennsylvania, and there's a couple other states that do this, where they say you basically have to have a pre-hospital RN credential. It's not a paramedic credential. A lot of the curriculum is very similar to what a paramedic would go through. In fact, one of the easiest ways, and this is how I got my PHRN credential when I flew in Jamestown, so we were so close to that PA line. You know, one option is if you have a nursing license and you have a Pennsylvania paramedic certification, you just put the two of them together and you become a PHRN, no additional schooling. And that's how similar those curricula are. But to actually have to go through the paramedic program and do all of the, you know, what is it, like 15 or 35 or whatever different, you know, IM injections and get signed off on starting IVs and all that sort of stuff, like that's just, there's no reason for that as an RN. And similarly, you know, to do all the ride time in the back of an ambulance, if that's not what you're going to be practicing, I don't think that that's really necessary. So I don't think that they should have to have paramedic credentialing. But then you take the flip side of that and you look at, you know, I don't care if you're an ER nurse, an ICU nurse, what flavor of nurse you are. We are not teaching our nurses in foundational nursing school how to intubate patients, how to necessarily, you know, extract patients from a vehicle, how to manage the logistics of a dynamically changing environment where, you know, you are not inside the four walls of the hospital and your suction device is on the wall of your ambulance or your aircraft, and all those different factors that play into things that EMS professionals are aware of. So I think that there should be some form of cross training in which a nurse is trained in those aspects of field care, and certainly those aspects of nursing practice that we don't get trained in as an RN, but are usually well within your scope of practice as an RN. Most states, they don't, you know, hospitals may not allow you to intubate, but your state nursing scope of practice doesn't usually say that you cannot intubate. It usually just says you can manage a patient's airway if necessary and trained. So that's kind of my thought on that. I mean, I don't like that, because we had to jump through that hoop with our folks. For a while, Kentucky actually did require that they have a paramedic on the aircraft. Didn't say the nurse had to also be a paramedic. What they said was there must be a paramedic on the aircraft to respond to scene flights. the way that we were operationalized at the time of my program is that the nurses and the Kentucky base was staffed with a nurse and a nurse practitioner most of the time. So really what we ended up doing is we ended up saying all the nurses go back to obtain their paramedic certification. They didn't really want NPs to go back and do that. And then the other problem was because we were NPs, if an NP had called out, they would backfill with a physician. So they couldn't require all of the residents down here to also go through and become paramedics. So the most consistent staffing model was the nurse at that base. So de facto, we required all of our nurses to become paramedic certified in the state of Kentucky as well. But again, they didn't really learn anything above and beyond what they were already doing. So I don't really see the value in going back for that certification.
Yeah,
That's my opinion.
that's kind of my view as well. All right, this is a big one as well. First of all, I'll ask you, you are family. So I want to preface this with what family and what acute care NPs do are very different state to state. So, but this is a common question that I'm asked, and I speak for Ohio because that's really the only state I know. So you yourself, are you a family or acute care NP? And then to follow that, and then I'm also gonna, you can answer the question if you're qualified in peds, but I want your opinion on whether people who desire to be in critical care transport should choose family nurse practitioner, acute care nurse practitioner, or potentially both.
So the answer to all of the above is yes. So I am right now I'm dual boarded in family and adult acute care. I'm also board eligible for pediatric acute care. I finished the program and I just well, let's be honest, I'm lazy. So I haven't actually boarded yet. Mostly because I finished the program right as we were getting rid of the flight nurse practitioners at my site. So there was no reason, there was no urgency to go ahead and take my boards. So I probably should do that. I recognize that I probably should actually like take those boards at some point. But I have not yet sat for my pediatric acute care boards, but I did complete the postgraduate training. I did complete the clinical requirements. So I'm board eligible. I just haven't sat. With that, I think that getting into your third question there about acute versus family, I mean, this is a hot topic on a national level, even for nurse practitioners within the emergency department. So looking at the broader emergency care setting, and I'm actually involved in a couple of work groups through the ENA and the American Academy of Emergency Nurse Practitioners on a national level, talking about exactly this. So my personal opinion is that the certification you hold really needs to match the patient you're taking care of. So I'm not like if you're doing this one thing, you must always be this person and if you have doing this one thing, you must always have this certification. It has to match the patient needs that you're likely to experience. Which means I think that I can pretty broadly say for critical care transport, by and large, when you look at the training, you look at the curriculum, I do strongly believe that those folks need to have acute care preparation. And unless you happen to be in one of the very few systems where you have a completely separate adult and pediatric team, and your adults never do pediatric flights, including your adults never go to pediatric scene flights, I think you probably need to have both the adult and pediatric acute care nurse practitioner if you want to function as an advanced practice nurse. Because otherwise, what ends up happening is like, oh, hey, we're an NP program, I'm an NP. And then you have a 5-year-old like, well, I'm a nurse today. And that's the wrong, first of all, it's the wrong message. But you're not really, you're not really practicing at the highest extent of your license, right? Because you are, for 12 other flights that week, you're an advanced practice nurse, and then you have that one pediatric flight, and now all of a sudden you're an RN. And with that though, then there becomes questions about how do you maintain competency at the advanced practice level if you're not regularly seeing the patient population. I think that's something that needs to be also considered. But I do think that for critical care folks that the ACNP is really the way to go. most FNP programs, and again, I went through an FNP program. I went actually through Case Western's FNP program when I was up there because I don't know, I just have problems with school. But I went through Case Western's FNP program, and it was very highly primary care. I mean, that's really what the FNP in general is taught to do. Now, are there options for the FNP to work in other EMS related situations? I'm not talking about critical care transport, but EMS in general, I think absolutely. Right? If you have some of these places like Los Angeles County, Austin Travis County, that are sending nurse practitioners, Baltimore City is also doing this. You're sending your nurse practitioners to some of these folks in the field that call 911, and they can pretty much be like tuned up, treated, streeted without having to waste the resource of an ambulance to transport them to the ER, waste the resource of an ER bed to do something that an advanced practice provider can do on scene. I think that could probably be, depending on that patient population that you're seeing, it could probably be done by an FNP because it's no different than an acute episodic visit in the clinic. But now if you have those same NPs and they're going to, the gnarly, car accident with like multiple people ejected and people like hanging from trees and stuff like that, they probably need to have acute care for that role. So I think it really depends on the role and what you're expected to do. But for critical care transport, for the patients that we're seeing, I really think that the vast majority of those programs are going to have acute care. Whether
Yeah.
or not you add FNP in there, maybe if you're doing some of the lower acuity stuff. I know Keith from Vanderbilt mentioned like some of their nurse practitioners will do like event medicine. Some of that might very well be, I don't want to say below the scope of practice of the ACNP, but they might be closer aligned with the FNP practice. You're at an event medicine, you have people that are coming in with very minor, like ESI 4 level complaints. You probably don't necessarily need an acute care NP in there, but also it's an acute illness or injury, so the acute care NP should be qualified to manage them. So whether or not you obtain FNP certification for those reasons is entirely up to you, but I think that for critical care transport, ACNP is the way to go.
Yeah, I agree. I think that's been the commonality. Uh, this is much opinion based. I will give some pushback on everybody needing to be pediatric certified, and there's bias there because I'm not, right? Um, but programs like the clinic who primarily, like if your population that you care for is 98% adults, I feel like that's okay. And having transported many children who maybe I'm not a pediatric nurse practitioner, I sure know how to set the vent, sure know how not to blow out their lungs. And like the common pediatric illnesses, I'm okay with. That said, I recognize I'm not your guy to do the isolate or the kid who's already in a pediatric ICU with multiple drips, right? That team should be a pediatric specialty team. So conversely, if you're a program like Robert's starting, who primarily transports pediatric patients, all those NPs should be pediatric certified. Do they need an adult to do the adult with an MI? I don't know. That's probably debatable, right? And we'll have a lot of different opinions on that going forward. But I think it's a tall ask to ask every program with nurse practitioners to be dual certified, because then what comes up is how do you maintain competency in both, which
And
is
and
So
these
that's
are
a
to be
question, Dave, or for you, Jacob. For Metro, we take care of pediatric patients. But I don't have the exact figures on me, but I'm sure that less than 20% of our patients, probably less than 10% of our transports are pediatrics. And really, of those, how many are truly that ill? How do you ensure continued competency and ensure continued really relevance with what's going on in the pediatric world if you have both of those certifications when you don't transport a large number of kids?
Yeah, and that really right there is $1 million question. I mean, having these discussions. So a couple of the things that we're talking about, like at the national level, is looking at adding additional populations into the consensus model to really cover with one graduate preparation the folks like us in critical care transport who have to see both adult and pediatric patients. And it's difficult to, first of all, to go back to school to get the dual certifications. you're paying twice the tuition, you're doing twice the clinical hours, you have to maintain twice as many boards, all that fun stuff. But that's the exact thing that's coming up in those conversations, to which I say, if you're not competent to maintain, if you're not getting the volume to maintain competency as a pediatric acute care nurse practitioner, how do we know you're even getting the volume to maintain competency as a nurse or a paramedic or whoever? Like, if you're not seeing those in regular practice, how are you staying proficient in your pediatric? I mean, PALS research every 2 years is not competency, right? Like, so I think that whatever we're doing to try to keep our pediatric proficiency at the foundational level, I think we can probably find a way to do that. And as we get further in on this, maybe if we want to practice as a advanced practice provider in transport, maybe the role isn't purely transport. Maybe there does have to necessarily be some degree of clinical practice in a higher volume setting, whether that's 1 or 2 days a month you're in the PICU, or 1 or 2 days a month you're in the ED, or 1 or 2 days a month you're in the CVICU, or whatever that is. But that might be an option. And coming from a place where I really didn't do that. But you look at Cleveland Clinic's program, and all of their nurse practitioners also work in the tele ICU there at Cleveland Clinic, unless they've changed that. I can't remember if Dave said that they are still doing that or not, but I believe that they all are.
They are.
Yeah, and you look at some of these other programs, I know Keith was saying many of their NPs are working clinically as NPs in other locations. Not all of them, but many of them. So maintaining those skills, I think that there's an intrinsic, at that professional level, there's an intrinsic thing to say. I mean, I went back through my procedure logs, and I think, in 2022, the last year that I was a full nurse practitioner for the entire year, I think I did like 3 art lines and a central line the entire year. You talk to some NPs in the ICU, and that's like what they do in a week, maybe even in a shift. So, I think that there's some value also in maintaining competency, not only in pediatrics, but also in adults, because we're not regularly seeing all these complex critically ill patients on a regular basis to maintain those skills. And with that, we kind of get into the RVU generation. So when we're talking about, how to substantiate the additional cost, even if you get paid exactly the same, there is definitely some additional cost at the institutional level, because now if you're a nurse practitioner, your malpractice insurance changes a little bit. So there's an additional cost there. Now it's not profound. If you have 10 NPs, it's not like it's going to bankrupt the entire health system, but you take 10 nurses and make them 10 NPs, and there are going to be costs that are going to be absorbed by the health system, even if you never see any of that. And then the second part of that is, of course, the nurse practitioner is going to want to make a little bit more money. So, let's be honest, it is what it is, right? And I'm not saying we shouldn't, but I'm saying that we will want to. So how does the health system kind of recover some of that? So if you're not generating those RVUs, that's considered, that's something we need to be considerate of as well.
Yeah, these are questions that administrators need to think of when they're starting a program. The other issue is, 20 years ago, 30 years ago, all the senior flight nurses were staying, right? Because they're at the pinnacle of their career. One of the issues that's a constant and that I've seen is the turnover for those senior flight nurses. They're driven, a lot of them, driven people, type A personalities. They go and they get a nurse practitioner. So now, do I go make more money doing something else? What are my options in critical care transport, So another thing to think about, is the turnover of flight nurses. And also with that turnover means the flight nurses coming in have less experience. You know what I'm saying?
Yes.
You no longer have that 20-year flight nurse who's been the old hat, done this a million times, paired with potentially a newer person. You may have 2 newer people in there. And I think one of the advantages of, even though there is maybe more cost with the nurse practitioner model, you have that constant, certainly they're going to need to be trained, right? But once they get to that proficiency, they're at the job of their life, right? So they're only going to be better and better and better. So there are a lot of things to consider with the model. And to your point about procedures, we've done this both at, you've worked in an ICU, right? Well, I can tell you on the aircraft, you're not going to get a lot of central lines and A lines. You get an intubation every 3-4 months or so. But if you get into a hospital, and now that varies depending on the practice as well, but there's a lot of my colleagues, a lot of my friends who are NPs, myself, will go on a shift. We'll probably intubate once a week, probably get 3 or 4 lines during that week. It all depends. But I will say the competency level, I agree. Reading about it and doing it are two different things. So that's another thing to consider, if you're starting a program, are the NPs just going to fly, or is there going to be a mix? And what's the right answer, I think, is probably debatable on who you ask.
Sure.
Okay, you kind of went over your path, I guess. But while I got you here, what's your recommendation for those who want to be both nurse practitioners in transport? And also, I get asked by flight nurses a lot, what's the general path if I'm just, let's say, done with nursing school?
Yeah, so I think that I kind of went into my path. I did med surg, ER, EMS, and then went into flight. But I think that the general, what I recommend for the nurses especially is getting ICU level experience. Now, when you jump down to specific training to prepare for an NP role in critical care transport, that's where I think that it probably is also beneficial to have. I almost don't know if that necessarily requires NP practice before becoming a flight NP or CCT NP, whether it's flight, ground, whatever. I do think you have to have ICU background, whether that's as a nurse or as a provider. I do think that you probably should have some degree of, it's probably helpful to have some degree of transport experience, although certainly not required. I mean, we don't ask our nurses to be EMS providers. We just had that conversation. Like, I don't think that that's necessary. But I do think you have to understand that environment in some way, shape, or form. What I don't know is that there's necessarily a requirement for an NP to have, when we look at our CAMES accreditation standards, they require you to have 3 years or 3,000 hours of experience in the discipline that you're working in the transport environment. So for a paramedic, that means 3,000 hours typically in a high volume 911 system. For a nurse, that typically means 3,000 hours in a academic ER ICU, ideally. But for a nurse practitioner, I don't know that the 3,000 hours of practice in a ED or ICU as a nurse practitioner is necessarily adding that much additional to their arsenal for critical care transport. Maybe some procedural things, as we've discussed before, like you're going to get a lot more procedures in the hospital, so you may be able to gain that procedural competence. But I think the decisions that we're making between the ICU and the transport setting are slightly different. Now, having ICU background as a provider, you do kind of start to think about kind of that patient's plan of care and where they've been and where they're going. So when I think about like you're doing an interfacility transfer from a community hospital ICU to a tertiary ICU for whatever reason, right? This patient's been on a plan of care in that ICU, and they're going to a center that is going to establish and maintain some of that plan of care and establish de novo some other things of that plan of care. And having worked in an ICU as a nurse practitioner, you kind of understand a little bit more of that higher level thinking. But I don't know how much of that we really need to understand in transport. Now, it might be very different if you are, doing one of those transports. For example, the gentleman is going from Israel to Cincinnati next week. Like that is a very long transport, and you may actually have to understand some of that because it's not just a 45-minute flight from point A to point B. Like you are actually managing these patients for multiple hours, and you actually are kind of doing floor nursing or ICU nursing at that point. But I think that for the vast majority of our transports, especially the rotor and the shorter distance ground transports, I don't know that there's really a necessarily advantage to having previous inpatient NP experience. Definitely think you need to have experience as a nurse. And we're not even going to get into the debate about should you even be a nurse before you go to NP school up front. The answer to that should probably be yes, but that's my opinion. I do think you should have experience as a nurse. Ideally, as a transport nurse would be great, but I don't think that's necessarily, the transport nurse is not necessarily required, and I think that the NP experience is not necessarily required. But understand there's going to be a steeper learning curve. What I do think, though, for that third question that's on the slide here is, should transport NPs regularly work somewhere else? And I think for all the reasons we've also discussed, I think the answer to that is probably yes. So, if I could envision my perfect transport team and my perfect transport setup, I would probably rotate our flight NPs through some kind of a unit. Now here's the question, like if you put someone just in, they're just split between the flight and CVICU. They may not be as proficient in neuro things or other things like that, or you put them in flight and neuro, they might not be as proficient with cardiac devices. So I don't know what that other place is. Maybe it's a regional float, maybe it's something else, but I do think that there's value in having them regularly rotate through some other kind of unit. Ideally, it would be done as part of their FTE. So, if you're a 0.9, maybe you are flight 0.6 of your FTE, and then in the hospital 0.3 or whatever that turns out to be within your program. But I do think there should be some kind of rotation, because this does a couple of things. Number one, it helps to maintain skill proficiency, as we were talking about. Some of the skills that nurses and paramedics are doing, we're not doing with any regularity. And now you want to add other advanced practice skills into that. We just have to be really good and really proficient with those skills. It maintains your clinical acumen, so you're seeing a higher volume of patients with a wider array of clinical problems, and you're thinking through their clinical management. You're getting a regular interface with the consulting specialists about those disease states. Sure, I can pick up a phone when I'm on flight, assuming I'm not in the air, and I can call the receiving CVICU and ask a question about this device. But if I've got 4 patients that are on pump, and I'm talking to that interventionalist, or I'm talking to that perfusionist, I'm talking to that cardiologist about these 4 patients for the entire shift, that gives me some clinical acumen. And the next time I see a patient that's on pump that I'm managing on ECMO during transport, and now I know when to ask those questions and when not to ask those questions, and what questions I've already actually have answered because I've been having that discourse with my colleagues on a regular basis.
Yeah. All we can do is give our opinions, having been in the industry, right?
Yes.
And I tell people, if you don't have transport or NP experience, you're kind of on the bottom of the totem pole. I think if you have transport experience or NP experience, you can mesh into the role, ideally you have both. That's kind of how I tier it. And, the argument for in practice provider experience is, hey, if we're going to say we're going to bring procedures and all that to the table, well, it better be pretty easy for you. I can tell you that, having been in the position where I wasn't really doing procedures all the time, yeah, I could get it done. I could put in a central line or something, but certainly not after you've done 100 of them, 200 of them, right? So again, one of the things that anybody starting a program would need to think about is, are the NPs just going to fly? Are they going to do both? I think there's arguments for both. I think it even works if they don't practice in the ICU or ED. I think they may be a little less procedurally experienced, but they're still smart, and I think they can still get the job done. And they do practice at a higher level than the standard of care, in my view.
Oh, absolutely. And that's, the program that I worked for down here in Cincinnati, we were exclusively flight. We had no other clinical requirements anywhere else in the hospital system. A couple of my colleagues had some side gigs as well, and I don't know if that's because they wanted to be clinically active or they just wanted the money. I mean, I don't really care one way or another, right? Like we all have our side hustles for our own reasons.
Yeah.
So yeah, absolutely. And I don't think that any of them were, lesser clinicians because we were just flight only. And same deal with, going up to, if you look at the Cleveland Clinic's model, I mean, those nurse practitioners are almost exclusively flight. And if they work in the ICU, it's that tele ICU. So they're really not managing the patient. I mean, they are managing the patients, but they're not like at bedside. They're not performing the physical exams. They're not performing
Yeah.
the procedures. So if we're going to say that the whole like you need to have them rotate through the ICU to get the physical exam findings and the discussion findings and the procedures. I mean, that's not that model either. And I think that that's probably, that is a very elite group of nurse practitioners that perform critical care transport.
Yeah.
So yeah, I don't think that it's a requirement, but I think also if I were designing my ideal system, I probably would.
I think
The
so
next
too.
question.
I think the mix is good. And the counter to what I just said is how often you put it in central lines in a transport? Why don't you put it in an IO or something? So
Sure.
there's nothing solid, but I think the perfect mix is a dual role, 50-50 or whatever it is. But all right, let's carry on. We kind of talked about this, but what qualities or characteristics make a strong APRN candidate in CCT, whether they are a new hire or an experienced NP?
So I think that one of the biggest one of the most important characteristics, and I don't know if this necessarily goes for APRNs or just everybody in general, is right flexibility, adaptability. One of the absolute hallmarks of EMS in general, whether it's CCT, 911, whatever, is that we work in highly unpredictable environments. We are making rapid decisions based on limited information of questionable veracity. So we really need to be flexible. But that also comes down to schedule flexibility, base flexibility. You're scheduled to work base 1 today, and then there's a call out, so they have to move you at the last minute to base 2. In the hospital, it doesn't really matter. Like you show up there and you are, if you're an MICU nurse practitioner, like you show up that day in the hospital, and if someone calls out, like it doesn't matter, you're still the MICU nurse practitioner. Like maybe they'll pull you to a different unit in the hospital, but you're still going to the same work. So I think that flexibility is very helpful. I also think that some of it is recognizing sort of why we're getting into what we're doing. We're trying to do it for the right reasons, and sometimes that means that we have to have some professional accountability to do things on our own to make ourselves be able to perform at the top, because we are probably in the unique role of we have to know kind of a little bit about everything. They say that about emergency medicine, but I think us even more so, because we're not only doing emergency medicine, we're also doing critical care. So you take all the stuff that emergency medicine has to know, and then you add in all the stuff that you have to know in the MICU and the SICU and the NICU and then all the U's, right? And you blend all of that together. There's no way that anyone is going to be physician, NP, PA, I don't care who you are, nurse, paramedic. Nobody is ever going to have that wealth of knowledge available to them. So there also has to be some accountability for professional growth and development. Whether that's going to conferences, whether that's listening to podcasts, reading journals, getting involved in professional organizations, whatever that is, there should probably be some evidence that someone is not there to just go to work at 7 a.m., clock in, run my flights, clock out when I'm done, go home, turn off, and be done until my next flight shift. There has to be continuing professional growth during that time period. I'm not saying that the work-life balance should be non-existent, like that's absolutely wrong as well. But there has to be some evidence of maintaining a professional growth. And it could be stuff that's done on shift too. I mean, the dirty secret is most flight programs are not flying 24/7. Most ground programs are not on the road 24/7. So some of this is very much like you can be doing some of the stuff while you're at work. I get journal table of contents sent to me. I listen to podcasts on my drive to and from work, really not when I'm at home. So, but there should be some evidence that you want to grow as a professional. That's absolutely necessary. And I think that there needs to be some ability to adapt to those. I don't want to just say environments, but you have to be able to adapt to those situations when they dynamically change. this patient is going to be flown. Now we're going to do ground. Now we got to do fixed wing. Oh, we're back to rotor. On second thought, we're going to do ground. Well, actually, we're going to rotor you out there. You're going to come back by ground. Right. Like that happens. And you're just like, okay, cool. That's what we're doing now. So sometimes those things happen and you have to be dynamic and you have to be able to accept those and you have to be able to work with the team to make a good decision based on that limited amount of information that we have.
You bring up a good point that I want to highlight. I talk about this in the paper, the downtime,
Mhm.
that's something that, number one, if you're going to ask for more money, you can't just sit down all day on shift and put your feet up, right? So the NPs need to be ready to add more and to provide the value. And that's a good time to harness the professional education they have, whether that's research, whether that's developing protocols, whether that's whatever they're doing. It's a good time to harness that extra advanced, whether it's doctorate or master's training, and add value to the program. Chart reviews, whatever. There's a lot of things that need done at the administrative level on these various teams. Any ideas on other ways to add value, specifically during downtime, Jacob?
Yeah, so I think I mean, so some of the things that we do in the so my program down in Cincinnati did not do this well. And honestly, I think that's probably one of the reasons why our program was not successful. We really didn't capture the highest extent of our nurse practitioners training, education, et cetera. And I'm going to actually go ahead and put in the chat a couple of resource documents. I actually, in full disclosure, I kind of co-authored both of these. One of them is the NAEMSP's position statement on use of advanced practice providers in EMS systems. And the second one is the AAENP's position statements on the use of nurse practitioners in EMS systems. And they go over a lot of those things that, outside of just direct clinical care, what can we use these advanced practice clinicians for? And Dave, you said a lot of those things, working on protocol development, working on research, generating that new body of knowledge for others to be able to substantiate what we're doing, whether it's we meaning nurse practitioners or we meaning critical care transport in general. You've got someone at a community hospital needing to transport a patient with chest pain. Who do they call? Do they call an ALS ambulance, a BLS ambulance, a CCT ambulance, a helicopter? What's the evidence base behind that? So, all those questions that need to be answered somewhere. Also, like you said, doing education, whether it's the informal, like, hey, me and my partner are just going to go and sim on something or voice run through a case that we had recently. Or maybe it's developing the education for a base training, and everybody's going to come in for their whatever frequency your shop does it, quarterly, monthly, biennial, whatever it is. You're going to come in for your training day, and that nurse practitioners are going to kind of lead that discussion or lead that case management or build those cases and be the facilitators for that. I think other things that can be done during that downtime, certainly, your quality audits. So the way that we had things set up in Cincinnati that actually worked very well was all of our charts actually went through 2 levels of review. So the first level of review was kind of a peer review with the flight nurses, and they would look for a lot of the gamut metrics. So a lot of the things where gamut is saying, like, these are your quality metrics, did you meet these quality metrics? That was something that our nurses were looking at. And then it went to the nurse practitioners to really look at the decision making behind. So we weren't worried about, like, did you get a glucose for this? Did you get, did you have the patient, do you document a plateau pressure, like all that sort of stuff? We were really looking at reading the HPI, reading the narrative, looking at that medical decision making, and did we actually do what was right for that patient? Because that goes, those are just things you can't really capture in a quick, like, yes, no gamut metric, right? Those are things that you have to look at it and be like, well, yes, the patient was on this medication, but they also had these comorbidities. So even though that's what the protocol says, probably we shouldn't have done that because of these other factors. And those are the things that you want a provider level individual to be reviewing. And, if you're in a system where that is your medical director, I can guarantee you your medical director is not reviewing 100% of your charts. I guess I can't guarantee it. There might be like one or two of them. I'd be willing to bet my medical director would if he had the time. But you know what I'm saying? Like that's the thing that you now have this workforce of, 5, 6, 10, 12, 15, however many NPs you employ. You now can spread that out and they can look at these charts during that downtime and they can provide valuable feedback to nurses, paramedics. Our program also flies with resident physicians. And even after removing the nurse practitioners from the program, we do still have residents on the aircraft. So these are physicians, but they're early on in their career. So being able to provide that level of feedback to them to say, hey, this is something that you might want to consider in the future, or, why did you do this? And sometimes it's bidirectional. Sometimes we learn from them because yes, we've got 10 years of experience in the field, but they literally just went over this in med school, not that long ago. So although I know how I've practiced for the last 9 years, they can say, hey, but have you seen this article? This just came out. This is the cutting edge of evidence. So there's also a bidirectional learning between folks when you are able to incorporate that level of QA review into your system. And I think the other thing that is helpful, and this is something that Cleveland Clinic did, but also helping with that throughput, helping with those triage decisions. Although the decision to transport a patient by a specific means of transport is ultimately up to the sending facility under EMTALA and COBRA and by statute. Having that provider to provider discussion to say, hey, you're asking for this asset. I think this other one might be more appropriate. It's not illegal to do that. At the end of the day, they reserve the right to say, no, I asked for what I asked for. Let's do that. But having that discussion, and I've had that discussion in both directions. I've had patients that they've asked to rotor, and I'm like, listen, I think this patient is stable for ground. We actually literally have a ground critical care transport team sitting in your parking lot right now that can be inside in 30 seconds. And I don't think the patient needs helicopter transport for these reasons. Is that okay? And I've gone the other way where I'm like, listen, I know you want to send this patient by ground, but this patient sounds sick. Would you be amenable to us sending our flight team out there? And having those discussions, sometimes that provider, that's all like they might be on the fence too. And just having someone to have that discussion with them is like, you know what? Yeah, I was actually kind of thinking of that. How often do we get to bedside and we have that conversation with that referring provider? And we're like, hey, I think we should do this. And they're like, yeah, I was kind of hedging on that, but yeah, since we both kind of agree on that, let's do that thing. So sometimes that's all they need to just have that conversation. So I think that that's a value added because now we're doing the right thing for the patient.
Yeah.
In some patients, we're actually talking them out of a $40,000 bill in favor of a much less expensive ground ambulance transport. And in some patients, we're talking about sending a higher level of care than was otherwise requested. And if your system is just like, they call, we haul, that's all, you're going to have that mismatch between the acuity of the patient and the services that are provided. I go back to I saw that she's dropped off, but I go back to that paperwork that paper that was done with, I believe, Dr. Minacci, Dr. Winkleman, and others at Case Western probably 15 years ago in AACN's journal about using that synergy model to match the patient's needs to the level and the experience and the mode of transportation in the critical care transport setting. And even though that was well over a decade old, I mean those principles still hold true. So that's one thing we can do is that triage, and then the medical control. We can't have an NP on every single vehicle that may not be cost effective. But having your ground critical care transport teams call into the NPs for medical direction. These are now individuals that are able to provide orders. Now, in some states, I get that they may not be able to provide an order to a paramedic because of EMS regulation. But for your ground crews, if they have a nurse on that run, you can provide a nursing order probably to that nurse who can then implement it with the paramedic. And the benefit of this is now you have an NP who, first of all, at Cleveland Clinic, when I was on triage, I would get the triage request and I would look up that patient's chart because I know that if I'm triaging this to a ground critical care asset, they are now going to be calling me when they have questions about this patient. So I now have the background on this patient as much as I can see through, through the EMR system and the interlinks between where the patient is. Sometimes if they were not at a Cleveland Clinic facility, it would be difficult to see their current record because maybe they were at a Metro or they were at, UPMC or wherever we were going to pick them up from. But I would get as much information about them as I could. Many of those patients were also Cleveland Clinic patients in the past, so I would have some of their background history on them. And I would get that background. And then when the nurse called me, I could make an informed decision based on knowing what I know about the patient's history, what the nurse told me, and also understanding transport and logistics. Right? Anyone who's listening to this, watching it maybe after the fact, who has listened to or who has worked in the EMS environment, like how often have you as an EMT or a paramedic called med control and you get like a doc who's asking you to do something that is like, I don't know what drug you're asking for or what procedure you want me to do, but that is most definitely not in my scope of practice because I have never heard of that before, right? So you get somebody who knows and understands our system, our environment, our practice, and the logistics and constraints that we are practicing within. And I think that makes for a much more efficient med control call because you're not trying to explain, well, I can't do that. Well, I can't do that. Well, I could do this instead. Well, I only carry this much of that drug. You get somebody who knows and understands that system. And I think that that's exponentially beneficial. And that also decompresses. Now that phone call goes to the NP, it doesn't have to go to a doc in the ER, the ICU, whatever. They can focus on their things. So I think that that's a lot of just downtime on shift stuff that those advanced practice providers can do to better the system and make that system more robust and that system more resilient to being able to function effectively.
Right. I agree. You just understand the logistics, like you understand the constraints because in the ICU, I might go this route, let's say starting this drip or whatever, but I know that's a challenge when it's only two of you in the back of a squad, you're 5 minutes out. So we'll go this route, maybe push
Right.
something or whatever. And I think having that provider who kind of understands it, the logistics, helps make, I think, cleaner decisions, better decisions. But hey, do you know of any programs that we can add to this list who use the APRN model currently?
So the only other program that I know of is TransAero, and I think someone else had mentioned that as well. So TransAero Medevac down in Roswell, New Mexico area, I believe.
Now, I went to look them up. So are they practicing as APRNs or that was the thing I couldn't figure out.
Oh yeah, they are. In fact, so one of the co-authors on that AAENP position statement, Warren Shawless, he's a nurse practitioner in Sturgis, South Dakota, and he actually flies down there they do like 96-hour duty days. Insane, but I guess their volume must be low enough to support that. But yeah, full, complete provider autonomy. So they fly with physicians, PAs, and NPs, paired with usually a paramedic, I believe.
So you have the contact. Can you share his info with me, and then I'm going to reach out to him and invite him and kind of get an understanding of what they do.
Yeah.
It won't be this year, but to a similar discussion.
Yeah, I can do that.
And,
but those
and
are
to those
really
interested, go ahead.
I was going to say, those are really the only ones that I know of. I've heard maybe they have like one APRN that's credentialed out at, where is Darren Brody? Is it UNM, I think, University of New Mexico, maybe, but I don't know that for a fact, and I've not met that person. So yeah, TransAero would be the only one that I can think of to add to that list.
Hopefully in a year or two, this is a much bigger slide. Maybe
Right.
maybe my goals are too big. Maybe it's 5 years or something, but we'll see. These are the leaders right here. I think
To
we
those
already.
wondering, really quickly, you had mentioned Scott Schweikert's article about the AAC and synergy model. To those, I put the link in the chat for people who want to see it. It kind of matches provider skill level to the appropriate patient. Really, really good article and kind of foundational to what we do right now in critical care transport. So the article is linked in the chat.
I think we kind of touched on this already. Do you have anything to add to the discussion about pediatric experience? I guess the other part of this question, is there anything specific on how somebody can enhance their resume if they want to be involved in CCT? I guess specifically as a nurse practitioner, but you can also talk if you're, say you're hiring a flight nurse, how they could prop up their resume.
Yeah, I mean, I think that there needs to be some avenue for gaining that pediatric experience. And I totally understand it. I mean, it's going to be political in some systems. We are struggling to find good pediatric experience just for our nurses because, in Cincinnati, the Cincinnati Children's Hospital is a completely different entity than UC Health that houses our transport team. There are other transport programs in the area that aren't even hospital affiliated, so they don't even have an affiliation with the adult or the pediatric hospitals. That's a little bit in a contrast to, like, for example, Cleveland Clinic, where there's Cleveland Clinic and Cleveland Clinic Children's that are all the same entity. They're all in the same, metropolis of a building or whatever, right? The entire city block that is the Cleveland Clinic, right? But they're all right there. So you could very easily say, we're going to have our nurses rotate through the PICU or the NICU or the whatever, unit in that children's hospital, versus other programs that can't. So I do think that, pediatric experience is, again, I don't know that it's necessarily that you must have worked in a pediatric ICU for X period of time. But I think that you definitely need to have a plan at the institutional level of how you're going to maintain, first of all, obtain, and second of all, maintain that competency in pediatric patient management. And I recognize that might be very difficult. Like I said, there may be some institutional barriers, there may be some political barriers, there may be just some time constraints, or let's be honest, money constraints, because the other part of this is, when we were talking earlier about having nurse practitioners on the flight line maintain clinical activity in the hospital as a provider, seeing patients, generating RVUs. That is a very different story than saying, I'm going to pay a nurse to go and observe in the hospital where they're being absolutely not productive. But they're really not, like, they're not even there to take an assignment. They're there to observe. We're not necessarily asking these nurses. Usually when we have these transport nurses go into the ICU, they're usually not working clinically. They're usually doing more of an observation. Now, if their preceptor allows them to do some stuff, cool, but like, they're not functioning on their own. So I think that that's something that we have to be mindful of, is how are we doing that and how are we affording all of that sort of stuff? So for the nurse practitioners, that might involve getting a regular, dual appointment between the adult and the children's hospitals. And, as we mentioned before, maybe part of your FTE is flight, and then part of your FTE is in the pediatric ICU, and part of your FTE is in the medical ICU at the adult center. And just rotating through those to maintain some level of competence in all of those patient populations that you are expected to see and care for, that may be ideal. And then the best part is, if you are working there and not just going there occasionally to shadow, if you're working there, you're generating RVUs. So it's not like they're paying you to do nothing. They're actually, if anything, you're getting more RVUs out of one shift in the ICU than you ever would an entire month on flight, because you're seeing the patient volume. So, that might be a good way to also look at being sustainable for having those higher cost providers on the aircraft. Put them in the ICU for a few days, and it may not perfectly offset the additional salary, but it's going to help generate those additional RVUs and help to offset the additional salary of those nurse practitioners on the transport team. And same thing, the scope of practice difference. I mean, that's going to come down to your individual state scope of practice, right? So, an acute care, adult acute care NP, probably in most states will not be allowed to do provider level things for a pediatric patient. A dual certified adult pediatric acute care probably can. But again, in some states, they actually don't look at acute versus primary. So an FNP may be able to do all those things if they've been properly trained in them, and if the state grants that permission to them. So I know that there are some states that fly with FNP or adult acute care plus FNP, and that allows them to provide provider level care to the pediatric patient. We've gone through my opinion on that previously, but in your state, if that is your legal scope of practice, that may be something that's permissible.
Yeah.
And yes, so did I work as an RN or paramedic before? Absolutely.
Yeah.
And do I consider it important? I do. I think you probably need to have. I think it's very beneficial to have that understanding. Um, and Dave, I liked your hierarchy kind of before with the conceptual. Like at the very bottom is someone who's had no transport experience and no NP experience, right? Because it's going to be very difficult to teach somebody how to be a brand new NP and how to be brand new in the transport environment. If you've got some of either one of those, now you're really only teaching the other half of that, and that's a little more attainable. And then if you've got somebody who obviously has been an NP and has been in transport before, there's far fewer things you have to teach them when they come on board. Do I think that a brand new NP who has never done transport will utterly fail in transport? No, but I think that again, as we're looking at how steep do you want that learning curve to be when you first get going, and how long are we willing to extend this person's orientation and all those other factors that we need to play into. So I do think the experience is important, but it's not if you have no experience before, like we will never consider you type of situation either. I don't think. I think it just depends on the candidate.
Agree. I think you kind of went over this, about how both programs you've worked for,
Yeah.
how they use them. And then we kind of already alluded to this, but basically the second question, what other responsibilities do NPs have in your program besides clinical duties? I guess this question is really looking for ways to add value.
Yeah, I think we talked about a lot of that. I mean, all those other things that they can do that would add value during those, non-productive hours.
I guess another good question is, what would you not do if you had to do it over again? Like, what would you avoid if you're like starting a program? Um, the top one or two things that you would consider we did this wrong.
So having worked at the time was very similar between Cleveland Clinic and UC Health. The way it was explained to us was very different. So when I went to Cleveland Clinic, they basically said, this is your salary. We are paying you for 40 hours a week. We are scheduling you 36 hours a week. Therefore, every single week, there are 4 hours that you are being paid that you're not working. So occasionally you'll have a late flight, or occasionally you'll have to come in for training on a day off. Understand that you've been compensated for that time already. That was one way it was explained. When I went down to UC Health, they said, here's your salary. You are salaried for X number of hours per year for clinical shifts. Oh, by the way, you have to come in for all this meeting and training on your own time. And if you stay late, well, we're not reimbursing you for that either. So at the end of the day, like it was the exact same thing. Like we're doing the same stuff. It's the same environment, but the way that it was just conceptually explained made it sound a lot better at one place versus the other. And I think that that was one of the things that led to a lot of dissatisfaction with our team was they wanted that down at UC was they wanted to be compensated for every hour that they were doing something for the program. And I think most people that are nurse practitioners, PAs, physicians, most of us are probably in a salaried position where that's, first of all, that's just not how that works. But second of all, going back to that desire to have that professional development, you need to be able to give some of your own time to kind of maintain your professional acumen for this high risk patient population that we're transporting. Now, again, I'm not saying that this is something where it should be like a work-life balance and like every single week you have an extra 12-hour day that we're just not paying you for. Like that's complete and utter nonsense. But I think that, when we're asking you to come to the CQI meeting once a month for 2 hours, and we're asking you to come to a nurse practitioner meeting for a couple hours every month or every other month where we discuss our own internal things. I think that those are kind of reasonable asks to do and not expect to get a couple extra dollars for doing those things. And that's why I kind of like the way that it was explained And honestly, I probably would not have known the difference had I not worked in the Cleveland Clinic system where they explained it the one way first. I'm like, that actually makes sense. Like, it's really the same exact thing. They're basically like, one place is saying we're salarying you for, I don't know, 1828 hours. The other one is saying we're salarying you for 2040 or 2080 or whatever the full time is. So you're still making the same amount of dollars. The dollars per hour might look different, but at the end of the day, your take home was my take home between the two shops was about the same from one to the other. So that means UC was on paper paying me a higher dollar per hour. But at the end of the day, when I looked at my tax returns, like the amount that came in was pretty much the same. So it really didn't matter. And the amount of work that I was doing was about the same. At Cleveland Clinic, we had our case review days, we had our safety training, we had like all those different things that as an NP, we weren't necessarily compensated for because we were salaried. But at UC, we weren't compensated for those either because we were salaried. But the explanation of how we were compensated for that was explained a little bit differently. And for that reason, some of my colleagues at UC were a little bit upset that they weren't getting paid for all these other things that they were doing. So I think that would be, if I had to do it again, I would probably try to rework the way that was worded, or include some of those non-clinical activities in the salary just up front and say, like, you're doing X number of hours of clinical work and you're also responsible for X number of hours of, non-clinical, proficiency or non-clinical training or education or whatever you want to call those hours. But just make it clear that that's included in your salary and it's included in the expectations.
Yeah,
And it's, yeah, go ahead.
that's a good point, because when you're hiring, my experience has been, if I'm posting an NP job, now granted, I'm not actually making the decisions to hire. There's a lot of people who want that job, Um, so if somebody, in my view, is not agreeable to doing a little extra for the salary, all else being equal, I'll take the person who is willing to do that stuff. Now,
Yeah.
like you said, can it be an extra shift every week? That's kind of pushing it, but you can't. To me, that's a reasonable ask to expect you to do more and provide more, your salary, work a little more here and there, you know, so it all averages out.
They just really need to be upfront ahead of time with what they're including in that salary, all
Yeah,
that
Oh,
extra meeting
absolutely.
time and whatnot. It just needs to be super clear from the beginning.
that's a good point. That's really a good point, Jacob. I'm glad you brought that up.
And that's the problem, is the way it was explained was like, they explained it as in you have to go to these meetings and this is not included in your salary, but we're also not paying for it. So it's like, well, yeah, I mean, that kind of sounds like you're cheating me out of something versus saying like, hey, we're paying you for non-productive time or whatever the case may be. And as a result, just understand that you've been compensated for this in other ways. So just again, exact same. And at the end of the day, it's the exact same thing. It's just the way that it's explained is a little bit different. And consider too, especially like anyone that's a new NP, these are individuals coming from a staff nurse position where they were probably paid hourly, meaning they were probably paid hourly for all those trainings, all those meetings, all those holdover hours at the end of the shift. Like all of that stuff, they are used to getting paid hourly for, where a lot of individuals that are coming like, PAs and physicians, like they're just used to the salaried model, it seems. And as a result, like it was kind of expected that, yeah, I have to do professional development on my own. But some of the newer NPs that are not used to a salaried environment are not like, they don't really grasp that. They're like, well, but I'm doing this for the company, therefore you should pay me for this. And they don't really grasp that there's, the whole concept of salaried versus hourly work sometimes. Not saying that they don't all, but like, if you got a newer NP that is coming directly out of that hourly position, just kind of understanding the difference may be a little bit challenging, because that was, my case coming from my first NP position, but it was explained very well. So
Yeah, I could see how that can happen, going directly from hourly all the time to a salary role.
there's honestly
Uh,
probably some days when the nurses make more than I did because they were hourly and on overtime and holiday bonus and all the stuff. And I can guarantee you some of them made more money than I did on certain dates.
Yeah, same here, especially during that COVID shortage. I'm
Oh,
sure
yeah.
it's getting crushed. Um, hey, what's your vision for CCT as a whole as it relates to nurse practitioners and advanced practice providers? And you can even include EMS in that, Jacob.
Yeah. World domination, I mean, clearly, right? So I think it really comes down to we need to look at the change in the patients that we're seeing and the change in the acuity, the change, and that acuity goes both directions, right? That's a bidirectional acuity. Sick patients are getting sicker. And then we have these lower acuity patients that previously would have gone to an urgent care or a doctor's office or whatever, and they're calling 911 because they can call 911 and get seen faster. So that acuity is going further and further in both directions. And I think we need to consider the appropriate models to match that patient acuity. If you've got a patient who is very dynamic, and I want to go back to Dr. Swickard's article, you have that patient who's got very dynamic changing needs that probably are not going to be efficiently covered in a protocol or CPG or whatever your program is calling it, and may need doses or drugs or something or critical thinking outside of the protocol, you probably need an advanced practice provider on that transport. And likewise, on the other side of the realm, for our EMS colleagues, some of the hospital systems have figured out that if we eat the cost of a nurse practitioner or a PA to go out in the community and dispo these patients in home, they never come into the hospital. They don't tie up a bed. They don't clog their throughput. They don't, burn an ambulance for that period of time that the ambulance is transporting them. And then invariably the period of time that the ambulance is waiting on the hallway to get that bed because it's tied up with 5 other people that didn't have to be in the ER in the first place. So I think that there's a lot of opportunity for advanced practice providers in the advanced practice model to strengthen our existing EMS system. And you look at the industry as a whole, and some of the stuff that David Pfeiffer from NKU, I believe that's where he's affiliated, are petitioning even for that within the paramedic scope of practice. To create this paramedic practitioner kind of analogous to a nurse practitioner. A nurse goes to do additional training, becomes a nurse practitioner, and can now do prescription and dispo and diagnosis. There's a model that's being proposed through NEMSAC where a paramedic can go to graduate level school to get that additional knowledge, training, et cetera, become a paramedic practitioner and potentially, diagnose and prescribe and bill and all those different types of things. And I'm fully supportive of that. I mean, one of the reasons why NPs and PAs are getting involved in EMS level systems is because that doesn't exist for paramedics. There is no career path for them to do that. Versus critical care transport, I think that, whether that's a paramedic practitioner, a nurse practitioner, a PA, depending on your state scope of practice, what they allow them to do, a physician, I think that there is a very strong case for having provider level individuals at that on those critical care transport teams. Am I saying that nurses and paramedics on the nurse medic team are, completely obsolete and there's no need for them, or that they're dumb, or they don't know what they're doing, or they're causing harm? Absolutely not. But I think that as that acuity starts growing, it is probably making a lot of sense to say that maybe there should be somebody there with that patient. You look at these really sick patients, they go into the ICU. You're not going to see these patients going into the ICU, getting transferred to the ICU bed, and there's going to be a nurse and a paramedic at the bedside, and they're just going to call in to the provider and be like, hey, this is what we have, right? That person is going to come to evaluate that patient when they first show up. And if they're a good provider in the hospital, when there's a change in that patient's condition, they're going to come to the bedside to evaluate and give those orders in real time. They're not just gonna be like, yeah, call me if anything goes wrong. Here's some orders, just, do whatever you got to do. They're
Yeah.
going to round on them. They're going to make decisions on them. They're going to see them every day. They're going to come to bedside when the condition changes. And yet we're expecting these patients, these exact same patients, to be transported in the interfacility environment or even the scene environment without that level of oversight. So
That's a really good point. You're saying this patient needs a provider and a nurse and where they're leaving and where they're going. But in the interim, it's okay to not have that. That's a good point.
yeah,
I
and
never really stated it that way, but I'll probably use it going forward.
Yeah. And, again, going back to Dr. Swicker's article, and looking at, the nurse medic model, I think probably for the vast majority of our crew HEMS flights, you're probably fine with a nurse medic model. I don't think that that model needs to die, but because it's going to be so difficult until you get to bedside and you actually evaluate that patient to realize who needs more, that's where I think that it's probably better to have those individuals on as a regular portion of the transport team. I can definitely see why Cleveland Clinic uses nurse practitioners, because their patients that they are flying are so highly acute that it is more likely than not they're going to need a provider. But then you have some of these other programs that are, they might be flying some of those to cover for that, and they don't have that provider on board. And unfortunately, we've seen that. I've seen that at several places that I've worked, whether as a nurse, whether as an NP, wherever. I've seen that in many different health systems where these patients come in and they are worse than when they started because the transport team just didn't really know how to manage that patient. And the reality is, with dead zones and restrictions and noise and everything, you can't always call med control when you're 5,000 feet over rural Ohio or driving through the hills of West Virginia, because you may not have cell reception. You may not have the ability to contact by radio. You may not have that ability to call out to a provider and say, hey, this is what I have. Or the amount of time it takes to fill them in on the backstory. That patient may be so dynamically changing that the decision needed to be made 3 minutes ago. By the time you finally explain what's going on, because this person doesn't know this patient, and you
Right.
finally get the order to do what you needed to do, you need 3 more orders to catch up to where the patient is, So
Yeah. I don't think med control works. That's because I'm a provider, right? Because there's certain things in a patient that you're seeing that are happening, that your brain is processing, that you necessarily won't be able to communicate in a phone call, and that the person receiving the phone call isn't necessarily going to grasp based on the words you've said. And especially for those dynamic patients, like they're just essentially, in my view, will likely reverberate a protocolized move to do with that call. I have found most, I mean, I don't know, if I'm talking to kid or things I don't do, I think maybe med control makes sense. But for me, and for the vast majority of my colleague APPs, a med control call is just a waste of time and really not benefiting me or the patient and the information I need, and the truth is, for most of my colleague APPs and myself, if I'm calling med control, it's not a generalized, nothing against ER providers, they're wicked smart. But if I have a CT ICU patient on ECMO, I certainly am not going to call an ER provider. I'm going to call a CT ICU colleague, friend, or whatnot. And the same with a neuro issue or whatever. Like, and I'll leave it at
yes,
that, I guess. Like, to me,
yeah, and
the ER
yeah,
provider is
and
nothing
that's like
against
closing that
them.
loop.
Yeah, go ahead.
And that's closing that loop and that nice space for repetition about like what do those NPs do during their downtime? I mean, it's a different story probably too if you are a nurse paramedic crew and you're calling into a flight nurse practitioner to get your orders, because they know you, they know the patient, they know the system, they know the constraints, versus calling into that ER. But absolutely, I mean, there's plenty of times, and some of it too is probably also like, just the comfort with having those discussions. I think sometimes that just because we're NPs, like we start to learn the vernacular and we start to learn how to ask questions to get the answer you want out of the consultant, right? So maybe that's a good reason to get some experience, is you know how to tease those things out of your consultants, inclusive of medical control. But yeah, so I think that's really where the benefit of acute care NPs in critical care transport is for those really super sick patients. Many of our patients, if you're flying a STEMI, if you're flying a stroke, if you probably don't need an advanced practice provider on those transports. But if you're doing that transport of that critically ill patient, and we're seeing those patients more and more frequently, hospital systems are regionalizing their care. Some hospitals, for better or worse, are holding on to patients longer. I don't know if it's just because they think they have the resources that they don't or whatever, but some of these patients are staying longer at outside hospitals, and they probably should have been transferred sooner. Some of these hospitals that they recognize they don't have the resources, but the patient is just so that sick. So we're seeing a lot of these patients, we're seeing this acuity, we're seeing these patients that need to get moved that are very dynamic potentially in transport. And that's where I think the value of the ACNP is. It's not necessarily in being able to put in the central line. It's not necessarily in being able to do a field amputation or a perimortem hysterotomy. That being said, when you have to do that procedure, you have to do that procedure. You don't have the ability to call for backup for those procedures. But so that is, kind of a side benefit, but really a lot of it is that advanced level decision making and the ability to legally step outside your scope of practice to do the right thing for that patient. I think that there are some really great nurses and paramedics out there that do the right thing for the patient. But if it ever got questioned, they would be in so much hot water that it wouldn't be funny. And if they're willing to take that on their own, I mean, that's their own decision to do between them, their family, and their board of nursing or EMS. But I think that not having to worry about that, that's what gives me the peace of mind functioning as a provider in the transport setting, is I know what my legal prescriptive authority is. I know why I'm doing things. I can justify my own clinical decisions, and I don't have to I don't have to worry about, did I violate my scope of practice because I stepped outside a protocol without calling someone to get a patient-specific order for this one drug? So that's really where I see a lot of the value in the advanced practice clinicians, is being able to rapidly react and not have to worry about, is this in the scope of practice? Is this in my protocol? Is this in whatever arbitrary line we drew in the sand for what a nurse can do and what a paramedic can do? We know as providers, we can just do it and it's fine and it's done.
So I think we've kind of already answered this, and this was more for the programs that we're using the NPs, but basically that's the goal as far as I see it. NPs, they go to school more, they provide some value, and they make more money than they would as an RN. So of the programs that are included on that list that we saw earlier, those programs pay their NPs, although I can't speak for what was it, Travel One or Trans, whatever you said there.
The
Trans Arrow.
Yeah.
Yeah, I mean, we did make a little bit more than the nurses. I don't know exactly what that number is because I truly don't know how much the nurses make. But we do make more than the nurses. We did make more than nurses, but we also made a lot less than any of the other nurse practitioners in the health system. And I think a lot of that comes down to, although our training requirements were higher, the RVU generation is lower. So I can see the argument of we should be paid more because we are highly autonomous and we have all this training that we go through. I can see that from the provider side. I also have an MBA in healthcare management, and I can see it from the facility side where that's cool, but like at the end of the day, you're not bringing any more money into the health system. Like maybe we can build some critical care time and get an extra couple $100 off of somebody, but those flights are so few and far between that where you're not really generating the RVUs. And that's where, going back to having those nurse practitioners rotate through somewhere in the hospital, you're at least offsetting the low RVU days on flight with high RVU days in a unit. And maybe that unit is a unit where you look statistically at where your RVUs are generated. And this way, when you're looking at from provider to provider, yes, I'm going to have fewer RVUs than someone who works exclusively in that unit or a different similar ICU, but I'm not going to have that low of an RVU generation that if I'm just working straight flight and I'm dependent on if the tones drop. And then the other part of this is, and this is a systemic issue, this isn't even right. When you're looking broadly at billing for this, and I recognize that not every flight NP program is billing, but if you are looking at billing for provider services, understand that there's the critical care E&M code is setting agnostic, right? It does not matter where that patient is. You can bill critical care time in a primary care office if the patient meets the time threshold and the acuity threshold for it. Unlike the primary care office, if we in transport don't have a patient who meets the definition of critical care time for acuity, or we're just frankly not with them long enough to meet the time threshold, there are no other codes that apply to EMS, critical care transport, out of hospital medicine, et cetera. You know, in the hospital, in the physician's office, if they don't meet the acuity, they can just bill a level 5 ED or office visit. In the ED, they can bill a level 5 or level 4 or level 3 or whatever ED visit, right? There is no like level 5 transport visit. It just is like, oh, patient wasn't critical care. Okay, we just don't pay you any money, even though you're a nurse practitioner doing this. Or, oh, the patient was critically ill, but you were only with them for 25 minutes. Cool. You don't get paid. Right? There's nothing else we can pay them. We can bill for those patients that don't meet that 99291 or 99292 criteria. So that's a huge limitation, because now if we're looking at taking those CCT NPs and putting them on even lower acuity transports, you know, that's one of the things that some of these places that are using, when you look at nurse practitioners that are functioning in the field and EMS systems, most of them are not getting paid for that. There might be some that are licensed as like mobile office visits, but by and large, if you have a nurse practitioner that's working for the EMS system, they're probably not getting paid. The only reason they're doing it is they're probably getting money from a hospital that is funding that solely because of they are not getting the dings from patients being readmitted to the hospital and violating CMS. They are not getting the throughput clogs. They're functioning more efficiently as a system, so they're willing to lose a little bit of money to pay that salary for that provider versus all of the downstream money that they're going to have to pay to see that patient in the hospital and treat them and dispo them and do all that workup in the hospital system. That's kind of where a lot of that money comes from. It's not because those NPs are getting paid by insurance to see those patients in the field most of the time. So that's a huge other system that we have to work through and figure out, if we really want to do this, how do we do it and make it so that we have a reimbursement model that will reimburse us for the time? Because critical care time is not the only answer. There needs to be other opportunities for other things that we are doing so that we can have that productive time when we are with those patients. And that's, I don't know that I'm going to solve that. And Dave, I don't know that you're going to solve that either. But that's a huge thing we have to consider, is how do we get that reimbursement? Because if we can figure out that structure, then that opens the door for more advanced practice providers to come in, because now we have a way to say, okay, if this patient was only moderately complex, you know, they meet a level 3, we can still submit that and receive reimbursement for those patients.
Yeah, I think it kind of gets back to, you got to call the right team too, right? If you have an
Right.
an ACNP or whatever on an aircraft, and you have like I don't know, a twisted ankle, you're not going to call the aircraft. You know what I'm saying?
Right, or you shouldn't.
Right.
But even some of the patients that probably need
Mike,
rotorcraft, they may not all need NPs, but then again, maybe they do.
yeah, I mean,
But they're not critical care, you know?
I think if you as a physician are going to say they're sick enough to need an aircraft, how can you not bill critical care time for that? I mean,
Yeah,
I
and I think
guess you can make that argument, but I would say the vast majority of patients would qualify for the meet the checks of critical care time. I mean,
sure.
I can think of some that should not have been flown, but that was probably on the sending providers. But
Right.
I think you can make the argument to bill a little critical care time on almost every transport, unless you don't meet the time, but then you can
Yeah.
say,
But
hey,
I mean,
well, chart review and all that.
but I've flown, and you have to consider also like other models. I mean, there are programs out there that are flying BLS patients, because, you know, some of these places out in some of like the Navajo Nation and those places, your two options are either you call a helicopter for this, or we take the only ambulance for an entire, you know, multi-square mile region out of service
Yeah.
for 16 hours to drive this patient into the big city.
I think almost every APN I know, yourself included, would agree that's not the ideal setting for
Sure.
provider-led model. So
Until you have that critically ill patient that needs the provider, you know, so that's the whole thing, is like, how do you efficiently do that? But I think that there needs to be some, you know, if they had an NP on that transport, there should be some way to generate some additional revenue just to cover that cost. It might be like a level 1, you know, however that system looks, right? It might be like a CCT level 1, that certainly is not going to reimburse anywhere near a critical care reimbursement.
Yeah,
But it should be at least be like, hey, there was a provider that performed an evaluation on this patient, determined it to be BLS, and as a result, like we are billing this level 1 or something like that. I think that there is some value to that. I mean, it's not like if you go to the urgent care with a a cat scratch and they look at it and say like, oh yeah, you're fine, put a Band-Aid on it. They're not just going to be like, well, yeah, they didn't really need to come to urgent care, so we're just not going to bill them, right? They're still going to get a bill. They're going to get like a level 1 bill because I evaluated it and I said it's fine. So in that setting, we're not saying like, well, that was below an NP. You didn't need to see an NP for that. You could have taken care of that at home. So therefore, you're just, we can't bill anything for that. Now the insurance might fight it. That's a completely different story. I'm not talking about who actually gets paid for, but I'm saying there should be a reimbursement structure such that when an advanced practice clinician is on a critical care transport team or an EMS system, there is some sort of a formalized structure in which they can be reimbursed for those services that they are providing as an advanced practice provider. And that's inclusive of physicians as well, because I know there are many systems where the physicians, medical directors, fellows, et cetera, will respond to EMS scenes and assist the EMS crews, and they can't get reimbursed for that either. So by and large, I think everybody that is doing this probably should have the ability to get some degree of compensation for that. If it's above and beyond your standard traditional EMS billing practices.
all right, we may have answered this. Are there differences in the scope of practice between CCT NPs and RN medics?
I mean, yes and no. I mean, there's a couple of procedural things like the resuscitative hysterotomy, field amputation. Although I've learned very recently that apparently field amputation is in the paramedic scope of practice in the state of Indiana. That was kind of cool to find out. But yeah, so really though, a lot of procedures, and we talked about this before, like, okay, if central line is not in your scope of practice as a nurse or a paramedic, how often are we really doing that in the in the aircraft? Arterial lines are probably the biggest one, but honestly, that's a false barrier because in most places that is well within the scope of practice of an RN to place a peripheral arterial line. It's just hospitals don't let them, or transport programs don't let them. So really the biggest scope of practice difference between a nurse practitioner and the nurses and paramedics is going to be that ability to function outside of the protocol based on their own prescriptive authority, right? There is no scope of practice on knowledge. Anyone that's watching this now or in the future can always go on to YouTube and find a dozen med school lectures, nursing school lectures. You can learn all the things that you need to know about how to perform brain surgery, short of being a credentialed neurosurgeon, probably from the internet. So there's no scope of practice and knowledge. The skill scope of practice differences, by and large, are probably not that vast to be real or important. And then the biggest scope of practice is really just having the ability to critically think, put everything together, and function outside of a set of protocols to individualize the care for that patient in that moment. That is the biggest scope of practice, and to do that legally, right? We're talking about scope of practice. Can nurses and medics do that? Many of them probably can, but can they do that legally? Again, that's a state decision, but probably not.
Yeah, I kind of agree. Like, here's how I like to tell people. It's not so much the procedure. I guess this would be an example. You're called to an ER with somebody who's hypotensive. It's unknown what type of shock, right? And certainly there's RNs and paramedics that can do this. But what a lot of my colleagues and I would probably do is, all right, let's figure out what kind of shock is this? Are they warm? Are they cold? Let's get out the ultrasound. Let's look at the heart. Let's look at the pump. Let's look at the IVC. And you piece this together to give individualized care. Not that all RNs or paramedics would do this, but the answer is not always just give three liters of fluid, just give fluid, or conversely, it's not just start a pressor. It's figuring out the balance of what's this patient need.
Exactly.
Yeah.
And like you said, I mean, there are a lot of nurses and paramedics that can do that. But now the challenge becomes, and maybe there's places that I figure out how to do this, but like, how do you write that into a protocol? Like, there's so many decision trees that go in there.
Yeah.
How do you write that into a protocol that now they can follow? And I get that some states don't require protocol. They allow their nurses and paramedics to work off of guidelines. So maybe that's not where an advanced practice model necessarily shines. But then there's other states, like when I practiced in New York State, they said absolutely there is absolutely no way that a registered nurse may ever choose which protocol to use because that is diagnosing, that is 100% outside of your scope of practice.
Yeah.
Um,
My
so
argument to those nurses and paramedics would be, you're learning these high level decision skills. Why are you not getting compensated for it? You
right.
know, I mean, you're bringing something to the table, and for those that do, they're driven, and I'm not saying it takes the RN license or the APN license to learn this, but it's like, that's the level you're bringing.
Yes.
All right, kind of getting near the end of this.
I think we answered that last one there.
I do
There are
too.
obstacles. Yes, there are.
So these are kind
Um,
of unrelated to APN, just critical care transport in general. And kind of you as a person, how do you stay up to date with the latest advancements and protocols in CCT? And then what strategy do you use to maintain your composure and effectiveness in high stress, fast paced environments such as CCT?
Yeah, so I think the keeping up to date, I mean, there's a lot of different ways to do that. The biggest way that I found that works most efficiently for me is I've got like probably at this point close to 50 different podcasts in my podcast app, all of which are medical, except well, I've got one finance one in there. And that is really helpful, curating exactly what you're listening to and looking at what those podcasts are. But I'll usually listen to a podcast on the drive into work and a podcast on the drive home from work. I'm fortunate enough in that I live about 30 minutes from the office when I'm working as the educator, and about 45 minutes from a couple of the bases when I fly as a nurse. And so I can hammer out a podcast or two on that drive. And that's helpful to stay up to date. And then the other thing too is a lot of these journals, especially if you have access to the journal through, like if you're at a hospital-based program, um, a lot of these journals, you can just go onto the journal's website and ask for their table of contents to be sent to your email on a regular basis, either daily, weekly, whatever, just the table of contents or all the advanced prepubs. And you can kind of just screen that and look through and say, okay, yeah, this looks interesting. Looks like it might apply to me. Pull it up, read the abstract. Oh, this really looks interesting. It looks like it's something that applies to me. Read the paper. And that's a way to kind of stay up to date on what's kind of coming down the pipe. And some of those things you might read before your medical director even reads, or before your colleagues even read about. So those are great ways to stay up to date. I mean, sure, there's conferences and stuff like that, and there's a lot of value in those. I think probably the two best conferences for CCT are going to be the Critical Care Transport Medicine Conference, CCTMC. We just had that last week before, recently, anyways, down in Orange Beach. That's coming to St. Louis next April. I forget the exact dates. And then the other conference that I actually think is really awesome, it's only open to flight crews, but it's the ECHO, Every Coast Helicopter Operations. And they're going to be in Richmond this fall. Certainly, sure, there's AMTC. I don't know, the value in that conference has kind of waxed and waned over the years, but as far as like actual academic cutting edge advancements in CCT, I would say ECHO and CCTMC are probably your two best options for conference venues for that. And then what strategies to maintain composure? The square breathing I think is helpful. I know someone kind of went over that at one point, I think, but just kind of doing that, breathe in 3 seconds, hold for 3 seconds, breathe out for 3 seconds. That's certainly helpful. Kind of going through and pre-planning with your partner, hey, if this, then this. I'm not as big of a fan of doing that solely because invariably you prepare for 5 things and then it's a 6th thing that you didn't prepare for that the patient presents with, and then it's like, well, great, what did we just do? But at least knowing kind of the logistics of a lot of times what, like on the flight out, like, okay, if this patient needs an airway, who's doing that? If the patient needs this procedure done, who's doing that? So at least then we kind of have our roles designated in advance, so we know, because like we talked about before, the procedural scope of practice isn't really that different between the nurse practitioner and the nurse or paramedic or whomever. So, I can do a pericardiocentesis, the nurse can do a pericardiocentesis. When I was flying as an NP, and even now as a nurse, I can do a pericardiocentesis. I can do a finger thoracostomy, nurse can do a finger thoracostomy. I can intubate, nurse can intubate. Like, most of that was very similar. However, there were those couple things like a resuscitative hysterotomy. Like if this is a pregnant patient we're going out for and she sounds like she's fixing the code, that's where we say like, okay, I'm gonna be down by the belly, you got airway, and you can kind of get that sort of done in advance. Another thing that's helpful too is just kind of like mentally rehearse those things that you haven't done on a regular basis. So, Bill Hinckley, who's my medical director, he says like he has done thousands of cricothyrotomies. Never on a real person in the transport setting, but he's done thousands of them in his head, just driving to and from his shift or flying out to a patient that sounds like they might need it. Close your eyes, visualize doing the procedure, what you're feeling, where you're palpating, where you're putting your fingers, where your equipment's laid out. Visualize that in your mind. And then if you have to do it, well, you've just done it, so you just do it all over again. So that can be very helpful. Some of that shadow boxing, just kind of thinking through those scenarios. I think that those are ways to kind of help to de-stress when you get into that situation, because the biggest cause of stress, I think, is I don't know what's going on. I don't know what to do here. And then that causes stress. So if you can tell yourself, I know what's going on. I know what to do here. I know how to do this. I've just done this in my mind 5 times. That can help to kind of de-stress the situation.
Yeah, I agree. I used to fly. That's all I did was fly. And when I check things off, when I used to check things off, and even when I tell residents, when like they would orient with me, you're not going to memorize everything in these bags, but it's an opportunity when you're going through your bags in the morning, you rehearse the procedure, you think in your mind, what do I need for, because you know the procedure right on paper. So a crike. So what do I need for a crike? Plus or minus the chloroprep. You need a 10 scalpel if that's what you're going to use. If you're not going to use that, you need whatever you're going to use, 11. You get into the neck, so you have your scalpel. Then what are you going to put in there? What size tube? You're going to use a bougie. Just rehearse this stuff. Same with the chest tube, airway, all the stuff that you go through, you rehearse the procedure. So I do like the mental rehearsing. And I'm even torn on simulation. Do you need to do the full gamut, or is it enough just to mentally rehearse that? I don't
Well, I
know.
think there's different reasons for both, right? The simulation, at some point you do need to do simulation. But I also think that there are a lot of, doing that mental rehearsal, I think is also, when we're talking about especially stress reduction. If I'm flying out somewhere that I think that I'm going to have to do a crike on that patient, I'm probably rehearsing that in my mind so that, again, it's just kind of fresh. But
Right.
do I think that I need to simulate that, like actually cutting a plastic mannequin or however you have it set up? Oh, for sure. Like there's definitely a utility in both of those things. It's just when you're using it and what you're using, having those just-in-time resources. So, other ways to de-stress are have access to your protocols. I mean, if you have protocols, policies, guidelines, whatever those are, have access to those. Have checklists available for high risk situations. Our pilots that we entrust with our lives in the cockpit of that aircraft, they don't do a damn thing without running a checklist. And I was just listening to a podcast the other day, and really what they said is if you don't believe in using checklists in EMS and CCT, I challenge you the next time that you fly commercial to go up into the cockpit and tell the pilots, hey, listen, very experienced, don't use your checklist today. I trust you. You know what you're doing. And see the reaction that you get from those pilots up there when you tell them just don't use a checklist. It's okay. I trust that you know what you're doing, because that's just not what happens. So having checklists available for those high stress situations. A lot of our procedures have like very quickly on the procedure, like with the procedure kit, they have just a really quick indication, contraindication, just like a quick like high level overview of how to do it. Because again, we recognize that if you are doing a crike, you probably have not physically done one in a very long time, if ever. You might have mentally rehearsed it, you might have simulated it, you might have done it in a cadaver lab, but you've not done it on an actual living sort of breathing patient. So, having those tools available to you, I think are very helpful. And then the last part that I want to say, for that de-stress is just also that open communication with your partner. Talking constantly through them, with them, running through the scenario, running through your primary survey, running through, okay, this is what we've done. What do you think about this? What do you think about that? What do you think about that? And having them challenge you as well. Okay, this is what we've done. Hey, have you thought about this? And having that open dialogue with your partner, I think is very, very helpful as well, because that helps to kind of keep everybody on the same page. And when everybody's on the same page, then there's a little bit less stress because we know what's happening, why it's happening, maybe why something's not happening. You tend to lessen a little bit of the stress in that situation as well, because it's very clear this is what's going on, this is what we're doing about it, this is what we're not doing, and this is why we're not doing it. This is our goal. Maybe if the goal is to get off the scene in 15 minutes, verbalize that. Say, hey, I want to get off the scene in 15 minutes. Now everybody knows why we're sitting around. Like, okay, we've still got a few minutes before we have to be off the scene. Or whatever that case may be. Or we have to be off the scene in 5 minutes, and therefore we're going to act very, very fast, and people aren't stressed out because, oh my God, like, why are they moving so fast? It's because, listen, this is a sick person. We want to be off the scene in 5 minutes. These are our priorities. This is what we're going to do. But have that communication. I think that a lot of times we don't communicate. And from a personal stress level, it helps me to be able to communicate to my partner, because they keep you honest, right? I don't care if that's a paramedic, a nurse, an RT, a physician, another NP, whoever that person is, right? They keep you honest. And sometimes they see things that you didn't. Sometimes they think of things that you didn't. And sometimes you think of things that they did. And sometimes you thought of it, but you didn't do it consciously because there's a contraindication. And then they ask about it, and you can say, oh, no, well, I thought about that, but this is why I don't think we should do it. So I think that that's a great strategy to use for, kind of de-stressing all those situations, because inherently what we do is often stressful, right? So.
All right. I mean, that's all I have, Jacob, unless there's anything else you wanted to add, or I don't see any chat questions in here.
No, I think I mean, this was a pretty long discussion. I think I probably have the record for the length of time, but as far as anything else, I think we should know, I think that it's going to be very interesting to see where we go. I think that it's going to be very interesting to see the adoption of this model. I want how places implement it. And I think that, having a venue like this to kind of discuss the best practices and see what is working and see what has not been working. Like I said, there's a couple things that I discussed today that I think were reasons why our program wasn't as successful as it could have been. And, those are important considerations to take into consideration when you're working on developing a program, when you're working on setting up a program, revising a program, when you're looking at applying to a program, if you're a nurse practitioner looking to get into something, some of those questions that you have could be that could help guide your decision. So, yeah, I think it's gonna be very interesting. And I think we're kind of at the very, very early stages of this, this subspecialty for our profession.
Yeah, I agree. I think what I'm going to do next is get all these, you, Robert, Dave, Keith, all of us together at once to exchange ideas and kind of go from there. This has been pretty cool for me to hear all the different viewpoints of the different programs. We've worked at the programs. What do you think, Tanner? You have anything to add or anything to say before we wrap up?
I think this has been super informative, and you brought up a lot of points that we talked about with previous discussions and with previous NPs, and kind of made some additional points. Like, I think the one thing that really stuck out to me was the having a provider and a nurse at the bedside at both places, but not necessarily in between. And that's something that we can use to justify maybe, especially in the sicker patients, having the NPs with us. But I think this has been a great summary, as well as some new points. And so thank you for your time.
Yeah, I appreciate your time. I know it's tough, so to get away for a day or a couple hours. So I am really grateful, Jacob, and I'll be in touch for sure on any of these going forward.
Cool.
Remember,
also,
flight camp, June 25th.
Do you what would be your thoughts about maybe even doing a panel discussion at like AMTC or something with myself, plus or minus, Dave, Rob, Keith,
I,
any of
I
the other
think it's
NPs
a
running the
great idea.
programs.
I think it's a great idea. I think, we would all be on board, and just give our insight, and it would be another platform, and we could have open questions from the audience and just answer the best we can. Hey, this is just, there's no evidence, there's nothing written here. We're kind of like saying NPs work everywhere else and they figured it out. Why can't we figure this out? And maybe it'll just take time, So I like that idea. Send me an email and then we'll round robin and maybe we can all meet wherever this is and have the discussion and have it multiple times wherever whoever wants to listen to it, because the best people to give insight are those that are doing it, and
Oh,
that have,
yeah, absolutely.
so yeah, really good idea. Let's make it
I think,
happen. Whenever the next one is, we'll do it.
yeah, I think AMTC's call for abstracts is closed for 2024, but
I know
and I
Robert's
know
on.
CCTMC is not. Yeah.
I don't know
Say
if
again?
he's listening, but Robert brings a lot. I think it would be an awesome discussion and highlight of AMTC. I think it would, yeah, it would be great. I would want it recorded for sure.
Cool.
Yeah, send me details. I'll probably edit some of this out, but we can talk or whatever. But I really like that idea. That's a good idea. Let's make it happen.
All right. Sounds
All right,
good.
man. Talk to you later.
All right. See ya.
Thank you so much.
Welcome.